Hello, everyone. My name is Jen Lee, and I'm the Director of Community Services and Partnerships at the Association of Asian Pacific Community Health Organizations, or AAPCHO. AAPCHO, the National Association of Community Health Organizations, serving Asian Americans, Native Hawaiians, and other Pacific Islanders. We're dedicated to promoting advocacy, collaboration, and leadership that improves the health status and access of these medically underserved communities, and are comprised of 33 members from across the nation and Pacific territories. Before we get started with the webinar, we wanted you all to take a few seconds to respond to a poll that's going to appear on your screen, just so we can get a better understanding of who is in our audience today. We'll just take a few seconds while folks answer the poll. Okay, we just went ahead and closed the poll. So it looks like, so our question was just whether or not your organization is planning on applying for the new access point that's currently available. And it looks like about 50% of you are planning to apply moving forward over the next 3 years. And about a quarter of you are planning to apply this year, and another quarter are still in your process of determining whether or not you'll apply. Okay, this is super helpful for us, so thank you for completing the poll. So on behalf of AAPCHO, I just wanted to thank you all for joining us today for our webinar entitled Defining Target Population and Service Areas, Some Considerations for NHOPI Community. As a national cooperative agreement funded by the Bureau of Primary Health Care, we're excited to present you with today's webinar on how to determine your target population and area for your future community health center. Joining us are your presenters today, Pamela Burns. Pamela Burns is a senior consultant with John Snow. She was previously the Director of Health Center Growth and Development at the National Association of Community Health Centers. Dr. Burns has a doctorate in sociology of healthcare systems from the University of Connecticut and a master's degree in research methods and applied statistics. She's served as a consultant to health centers, primary care associations, and community-based nonprofit organizations for over 20 years. Dr. Burns served on the Connecticut Legislative Commission on the Uninsured and has provided extensive legislative testimony on healthcare policy and legislation. She's held an appointment as Assistant Clinical Professor in the Department of Community Medicine at the University of Connecticut Health Center. I also wanted to introduce you Michael Byun. Michael has worked for over 15 years on health disparities, social justice, and immigrant and refugee issues. He focuses on Asian American and Pacific Islander and other underserved communities. Michael is the Executive Director of Asian Services in Action, the largest comprehensive AAPI health and social service agency in Ohio. Michael holds an appointment from Governor John Kasich to the Ohio API Advisory Council. In May of 2014, he was elected as Vice President Barack Obama to the President's Commission on AAPIs. Michael frequently speaks on panels and serves at various national level advisory boards and committees to address public policy issues affecting AAPIs, immigrants, and refugees. He's a Robert Wood Johnson Foundation Fellow, a Seattle native. Michael received his MPA from the University of Washington. We are super excited to have both folks here today, and hopefully have some chance for Q&A at the end. Just a couple of housekeeping items before we get started. I wanted to let you know, right now you're currently looking at an example of the GoToWebinar attendee interface, which is made up of 2 parts. The first is the viewer window, shown here on the right, but maybe on the left of your screen depending on your browser or computer operating system. It allows you to see everything the presenter will share on their screen. The control panel here on the left may also be on the right of your screen. It allows you to participate in the webinar. Please note that all attendees are in listen-only mode and will be muted for the presentation. By clicking the orange arrow button, you can hide or show your control panel. You can also set the control panel to auto-hide or not to auto-hide by going by the View menu. You may submit questions in writing during the presentation by typing them in the questions field, and please indicate to whom your question is directed. We'll be reviewing them as they come in, and we'll have a Q&A period following the presentation. Today's webinar is being recorded, and you will receive an email with a link to view the recording at the end of the presentation webinar. With that, I'd like to go ahead and hand over the presentation to Pamela.
I'm unmuted. Hi, thank you, Jen. How many folks are actually on this call? Are you there?
Yes.
Okay.
Currently 12 on the line, Pam.
Okay, great. I was just wondering. And I did want to say, just as a preface, I'm probably well on to over 30 years now of working with health centers. I think I need to change my bio blurb. But anyway, thank you very much for inviting me on. Today, I'm going to do two different things, which are really kind of connected. What I'd like to do is to give you an overall picture of how service area and target population interact with your program development and your proposal, and then talk about some of the challenges and the differences that organizations that are serving populations such as the AA&NHOPI, even similar to gay and lesbian, bisexual, transgender populations, and other populations that are spread out geographically but share a common cultural need and therefore require or are benefiting from services that organizations that are designed specifically for those populations can provide. So why don't we get into the slides, because I do want to keep within my time thing. And at the very end, I would like about 3 minutes to just address the poll results that we just had and some of the horizon we're seeing for potential future funding or lack thereof. So if, Jen, you would remind me at the very end to just take 2 minutes to talk about that so people have an opportunity to think it through, okay?
Sure.
How do I move these slides? Can I move these slides?
You could just let us know, Pam, and we could prompt it for you.
Thank you. So what I wanted to do first is to just talk about the logic of building program. The needs assessment is what actually leads to the development of the program. The success of the health center movement over the last almost 50 years and the success of every individual health center is based on the fact that the target population is understood very clearly. Not only their needs in terms of their health disparities and other things that we're going to talk about in just a moment, but also because the way that the interventions are designed, that these services are delivered, are culturally appropriate and culturally competent, so that not only are they there, but they're really able to be utilized to their fullest for the best possible outcomes. So the needs assessment really feeds into the thought process of planning the health center and then the strong health center program. There are 3 different aspects of need that you identify in building your program and in identifying your target population, your service area. Next, those are the health disparities. Next slide, please. Thank you. Those are the negative health outcomes that your target population experiences compared to other populations. Remember, it's always compared to, because you're trying to set up an argument that you're then going to show what the resolution of the problems are by telling your program. By the time someone gets to your program, it should make perfect sense because you've already told them what the issues are. So again, the first is the health disparities. Second slide is the, or next slide, is access to care. Those are the actual quantified number of full-time equivalent to primary care providers that are available to the target population. And it's important, again, that we're always focusing on the target population because we want to build that system that relates very directly to the people that we want to serve. The third component of it is barriers to care. Next slide, please. Even if there are adequate health resources out there, why can't the population that we're building a health center for access them? These three things create the opportunity to design the program. Next slide, please. So your health disparities tell you what services are needed. What are the different areas that people are experiencing negative health outcomes compared to the general population? The access assessment and limitations tells you how many of what kinds of different providers do you need in order to address those disparities. And thirdly, the barriers tell you what kind of service delivery model and strategy, freestanding, mobile, hours of the day, days of the week, all those different kinds of decisions that get made to maximize access and assure that people will be able to come in for care. So let's look for a minute at the different levels of description. Next slide, please. At the very basic is the service area. We start out by defining service area compared to the general population. We'll then move to target population and say, what is it that these folks experience? What are they like compared to the rest of the folks who live in our geographic area? And then finally, for folks who are providing care already, how does that relate to the existing patients that we have? The patients that we are presently seeing, we can't use the data on health disparities, access, and barriers because it's not population-based data. People come to be patients for systematically different reasons than people who don't come to be patients. So we need to go out into the general population and access or develop on our own population-based information to be able to understand. We call it the tip of the iceberg, or the iceberg phenomenon. The patients we can see, we understand them. What we're trying to figure out through defining our service area and our target population are who are all those other people we don't really know anything about. Next, please. And you can go right past the next one, which says service area. So the service area is a geographic space that your target population will be drawn from. This is one of the ways we run into difficulties or complexities in dealing with the populations that you serve. And again, as I said, it's similar to those who serve LGBT or other geographically dispersed populations, because unless you're in a city, for example, Charles B. Wong in Manhattan, who is serving a Chinese population in Chinatown, and it's very geographically defined, although they do get people from out of their service area. Many of the populations, and Michael's going to talk a bit about this too, because they had exactly this issue, was resettlement communities, refugee communities that are really all over the place. And since you're doing a culturally specific health center, you're trying to serve people, but they're not in a clearly defined geographic space. So that's one of the difficulties we run into. Looking at that, of course, we want to look at potential health risks, decreased barriers to care that people experience in that service area. Go ahead. Next. 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 Thank you. Now let's look at the target population. Next. Within that service area, the target population are those people that we're actually designing a program for. This is what they look like. This is where they live. This is how their daily lives are compared to the rest of the people who are in the service area, but are not the people that we're actually designing the program for. We're going back again to what are their health status, what are their access, and what are their barrier issues that we can design a successful program to respond to. So here's again where our problem comes in. We're trying to build a health center for a group of people that will be maximizing the positive outcomes at the same time that they may or may not be living in proximity to each other. It's not a clean space. So there are two different ways that you define this target population in your service area. One of them is the need for assistance worksheet in your new access point guidance. Next, please. Thank you. In the need for assistance worksheet, the majority of it allows you to actually focus on your target population. The problem there is that if your target population is made up of disparate groups, so you have a refugee community in the north part of the county, and you have a resettlement group of another population that's in the south part of the county, you have to aggregate all that data because you can only in the end have one target population. You can't have 6 different target populations when you're doing your data points. In your narrative, you can certainly address in narrative form the differences in the subpopulations. For example, if you have a Vietnamese group and you also have a Laotian group or a Hmong group, you can certainly address those differences when you're having your discussion, but your data points must aggregate all that data. So it makes it very, very complex the broader you get in who you're targeting. The 2 areas that you have to report in service area is where you run into an even bigger problem. Because the broader you define your geographic service area in order to be able to encompass all those various target populations, the more you're going to have those other people, if you'll excuse me, the people who are not uninsured, the people who are not living in poverty, in effect washing out your need data. So it's kind of the push-pull of you want to get all of your target population potentially included in it at the same time that you don't want to include all those hundreds, maybe hundreds of thousands of other people who will bring down your need data because they are not below 200% of poverty and they're not uninsured. This is a particular problem with populations that are the target populations who are going to tend to not be a part of Medicaid expansion or have access to other of the Affordable Care Act insurance products because they'll tend to have a significantly higher rate of uninsurance and most likely population below poverty. They also tend to work more in those places in industry that won't offer employer-sponsored health insurance and may in fact be working under the table as well. So moving on to the next slide. Moving on to the next slide. Thank you. I already talked about this. So what happens in reality? We had one situation where, for example, one of the organizations we worked with previously, which has gotten funded, we're very happy about, and they're in California, they were working with a very large county that had over 1.7 million people in it. But the populations they serve, people would travel to come to them because they're a culturally competent health center and basically the only option, particularly for English language restricted populations. But when they moved it to the county level, they had to count all those other people in their service area populations. And so it became very difficult because the number of people who were not target populations far outweighed the people who were. So it's kind of, again, a balancing act of trying to make sure that you're not washing out the real need of the populations you're trying to serve, while at the same time you're trying to make sure that you're reaching out and actually providing access to the populations that very much need to have it. Another issue as well is when you're looking at, so why don't you go on to the next slide first. So in balancing it, this is where you can go to the anecdotal side. And I put in a little bit of an example here. While the overall service area has, 4% uninsured, its data from whatever other source that you can get demonstrates that actually 40% of our target population are uninsured. Trying to work that need narrative to pull out the actual experience of your target population. Given that you're forced to use those 2 service area level data points creates the problem, and the fact that that need for assistance worksheet is going to go through an electronic scoring mechanism also creates a problem because 20 of the 30 need points come out of your need for assistance worksheet. So that's where you have to keep running numbers and going, back and forth on what makes sense. It's important also that you take the time in the target population, next one please, the target population definitions and descriptions and your data points, next slide please, thank you, that you use the data extrapolation methods that are allowed. They're available in your data resource guide that the Bureau puts out. It's indirect standardization or doing data projections based on observed and expected. It's a very well accepted biostatistics epidemiological method. It's important to do that because very often the CAM numbers that you get, those that are existing in secondary data sets, are either going to be at a too broad level or a too general level to really focus in on the populations that you're going to serve. And we can walk you through those at any point, that methodology, if anybody wants to do that. Not today, but another time. The other problem too, or the other thing to be really careful of when you're doing this, is to balance the size of your target population against what it is reasonable to provide. Going back to a similar example to the one on the service area, so you have this county and there's 1.7 million people in it, and your target population comes out to be about 120,000 because that's the population that you're defining, and then you say you're going to be able to serve 6,000 people. It really is an illogical connection or lack of connection. There's no, you know, oh great, there's 120,000 people out there and you're going to serve 6,000 of them. Wow, that's wonderful. You know, it doesn't really create a logical program when you're defining such a massive universe, but you say, yeah, no matter what, we're only going to do this little bit. From a logic perspective, for the reviewers, it makes more sense to try to be a little bit more concise and focused and anticipate being able to add sites that would address populations perhaps that are on the broader, you know, the outside skirts of your service area, or that you can shrink your service area, focus on closer populations and try to address those first with an eye toward growing in the future. It's become more helpful in recent years because HRSA and the Bureau of Primary Health Care have actually understood that there are populations out there, such as the populations you serve, the LGBT populations, the HIV/AIDS communities, people at risk for HIV/AIDS, who don't all live in a very close proximitous area, but rather are spread out. The statute, unfortunately, only defined migrant seasonal farm workers, people who experience homelessness, and people who live in public housing as the statutory special populations. But I think that folks are becoming to realize that the populations that you serve, like the others, have an awful lot of characteristics in common, particularly with migrant seasonal farm workers whose camps are spread out all over the place. And they have been allowed through the statutory definition to define things differently than you can. I think that pointing that out in your narrative is an important thing to do, because it says, you know, basically, listen, we're not that different from the other special populations in terms of delivery strategies and in terms of really maximizing access potential for our populations. They're very similar, in fact, to the special strategic thoughts and program designs of the populations that are already defined in statute. It helps the reader understand better why it is that you're making the argument and designing the program that you are. I think that that's all I was going to say. I'm 3 minutes over. That's not too bad. I think I do.
Jen, I know you wanted to just comment a little bit about the initial poll for the group on the call.
I can do that now, or I can do it after Michael. Doesn't matter which, as long as you remind me.
Okay. Why don't we go ahead with Michael's section, and then we'll come back to it. Okay, great. Thanks so much, Pamela. So before we have Michael go ahead and start, I just wanted to prompt, we have 2 more flash poll questions that we'd love for you all to to complete, the first of which is, have you attended any new access point training provided by the National Association of Community Health Centers? And the second question you'll see shortly is, have you connected with your state primary care association? Great. Okay, thank you all for participating in the poll. So I'm going to next hand it over to Michael, who's going to talk to us a little bit about ASIA, his organization in Ohio, and their geographical layout of the population that they were working to capture, and how they decided on their final target population and service area, and how that fit into their organizational strategy. Okay, it's all you, Michael.
Thanks, Jen, and good afternoon or good morning wherever you are. Again, Michael with Asian Services in Action, and I don't have slides to present. I'm really just going to talk story and share with you from an executive director of a community-based organization and how we went through the process and eventually became a federally qualified health center. We became a FQHC in November of 2013. But it was certainly a love of labor and many years of hard work and listening to the community. So before I go into some of the different aspects of how we came about in determining our need and recognizing kind of what do we want to present in our narrative to HRSA for our new access point application, I want to give you a little bit of the context of where we are situated so you understand better the work that we do. So Asian Services in Action is located in northeastern Ohio, and we're in the Midwest. Our community is in and around the greater Cleveland area, if you know Cleveland and where Cleveland is within Ohio. Our population is also very unique. We're geographically fragmented. There aren't necessarily ethnic enclaves throughout the region. So there isn't really like a Thai area, there isn't really a Vietnamese area. So we're all kind of scattered. And you know, that poses some very unique challenges as a community-based health and social service agency as far as where do you site resources and support for the community, given the fact that everyone is all spread out. So in 2009, in the fall of 2009, we began to hear from the community challenges facing them with regards to healthcare access. It really started with a story that one of our managers heard from the community, a woman, an elderly woman who had been coming to our program. What our manager noticed, you know, how she was pretty sick, and so our manager monitored her from time to time as she would come in to our program, and eventually, you know, approach her and say, listen, what's going on? You seem really sick. Aren't you going to a doctor? And she's like, no, 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 I'm going to wait. I don't need to go. And our manager was, more, you know, consistently persistent and asked him over and over again, and eventually the woman shared with her that she is waiting to take a bus that leaves the greater downtown Cleveland area every night at midnight and takes folks to New York City's Chinatown for health care. And this is despite the fact that we have the third best health system in the country, the Cleveland Clinic, within just a couple miles from the area known as Asiatown, which is not necessarily Chinatown, but it's just a collection of different Asian businesses and things here in the greater Cleveland area. So that prompted our board members and our senior staff to really reflect and figure out what is going on and how can we go about serving this population. And to that end, we had decided to move forward in looking at pursuing this federally qualified health center program. Part of the work that we've done is really to rally, you know, pull together a rallying call to others at the regional and national level to raise awareness about the fact that there is this unique population that doesn't necessarily fit into HRSA's current guidelines for determining underserved communities. As Pam had mentioned. Often, they're looking for defined geographic space, and our communities don't necessarily fit that. And so we weren't thwarted by that in terms of the challenges that it may involve. We decided to continue to move forward and figure out how to best approach this. The service area that we're in, which is in the Midtown area of downtown Cleveland, is pretty underserved. Currently, there are over 11,600 that are uninsured in this service area. In addition to that, we have additional FQHC partners, mainstream partners that work in and around the service area. And so as you move forward in deliberating in terms of your application, you will kind of come across this area of politics that is involved in terms of ensuring that you're able to put an application together, because there is this unspoken, I don't know, maybe Pam could verify this or not, but there's this unspoken notion that you have to get blessing from the other federally qualified health centers in the area in order to move your application forward. And that blessing is in essence, support letters to support your application. So in determining the service area, it's really important to, first of all, reflect on what is your actual service area. And in our case, it was a little bit challenging. We have a population that's geographically fragmented and dispersed across the region within a 40, 60-mile radius. But we also have this neighborhood, this particular neighborhood where we're situated, where we have some businesses, Asian businesses, that are located there. And as you may or may not have experienced in different parts of the country where you're from or have lived, in instances where there's only one Korean grocery store in a particular area, people are going to drive there, 20, 30 miles each week to do their grocery and other shopping. And that's what we've seen as well, is that our population has this unique pattern of movement, which would make sense for us to have a health center situated in this Asiatown neighborhood in Cleveland, because people do come to worship, to do their business, and to do other activities within the Asiatown area. And then also in that particular neighborhood, we do have residents who are primarily Chinese who do live in this area. In addition to that, we have Eastern European, African American, and also white communities that live in this area. And it's an urban area that's low income, predominantly low income. We have distressed housing situation where there are vacant homes. So it's, if you think about the Rust Belt of Midwest, that's a really good picture of what downtown Asiatown area is like. So as we kind of went through this process of determining this need in the service area, I think there is this importance of balancing kind of what you want to accomplish for your community, while also understanding what HRSA is asking of you. And it doesn't necessarily mean you need to sell your soul to the devil, but it really means that you have to be very thoughtful in creating and crafting a needs statement that not only addresses what HRSA's requirements are, but also stays true to your mission and your organization. And the way that we accomplish this, and I think Pam alluded to this a little bit throughout her presentation, is that you need to balance and gather really good evidence of your community's need. Again, the more specific that you can pull together data about your community, the better. And in addition to that, we access resources through which you will become familiar with, is the UDS mapper that is available through HRSA to allow you to determine what's the underserved population in your area, how many are underserved, what are the other FQHC partners in the area that are serving folks, so you can determine and figure out what your geographic boundaries are, your service area. As I mentioned to you before, we had, when we did our initial look, we looked at a 3 zip code area within the surrounding part of Asiatown, and we determined there were over 11,600 uninsured people in this particular service area of 3 zip codes. And from that, we determined in terms of what our capacity, where do we think we can serve the most, and we came up with a number that was around 3,000 at full capacity. And so as you can see, if you spend some time and carefully kind of figuring out what your needs might be and come up with a compelling case, the number isn't really that critical as much as your sincere effort to serve a particular population. And so for us, that number relative to the other FQHCs in the community or nationally is pretty modest. It's a small, modest number, and I think that we feel comfortable as a board, as an organization, that we feel that we can serve their needs the best. The other important thing that I want to share before I pass it over, because I think I'd like to spend more time, I think, in the Q&A section in order to answer your questions, because I know folks might have some hesitancy in terms of, oh, how are we going to struggle with the fact that we have this particular ethnic group, say it's the Filipino group or the Native Hawaiian group, that we want to serve, but they don't necessarily fit in neatly into this box in terms of service need or areas. And I would just say that it's really important as you move forward to seek some consulting support from those in the area, those who are well versed in developing and preparing these applications. And certainly AAPCHO could give you some recommendations on who they are. What we did in our case is that the needs statement, the application itself is pretty big. It's pretty overwhelming and sizable. And certainly it'll take an army to pull it together, and it's not necessarily impossible. But I think the area that where we as an organization spent some time and focused our energy in getting some TA or consultants to help us is the needs statement. And I would strongly recommend that you consider making that investment to bring someone in from the outside to help you, to work with you to determine that needs statement, the service area, the geographic service area, and the population that you want to serve, because they can help guide you through this process. So I think the last thing I would say is that, again, we're one of those success stories in terms of being able to become an FQHC to serve our greatest need population, despite the fact that there were tremendous barriers as far as fitting into HRSA's kind of rubric of who they want to serve. So I would say don't get discouraged, stay positive, and move forward.
Thank you so much, Michael. I think it's incredibly helpful. I wanted to let folks know that right now we wanted to encourage you to submit questions in writing via the chat box that's on your webinar toolbar on the right. If you have any questions, you can click the raise your hand button, and we will go ahead and unmute your line. And while folks are submitting questions, I know, Michael, I wanted to ask you just in terms of when you were in the process of determining the service area and trying to get the data to know what the uninsured rate was in your area, just what key data sources you used that were extremely helpful in kind of compiling that service area together.
Sure. So there are local resources that are available and also national level resources. Locally, we have an initiative here with the healthcare systems called Better Health Greater Cleveland, and they've been charged to work with the safety net providers, which include the federally qualified health centers and the major healthcare systems, to basically collect key data and health indicators across the entire region, across the systems. And so there are particular outcomes that they're looking at, indicators such in the areas of diabetes, cardiovascular disease, asthma. And that information was really valuable because it's localized data that gives you a specific kind of measure of what the population's health is within our service area. The second thing we did, one of the things that we were struggling with and had some challenges is related to what extent the current providers in the community were penetrating our population. And our community has some one of the unique challenges is around language access to healthcare services. And there weren't readily available data to determine the number of providers that would be able to provide services, and if so, are they taking any new patients? And so we did our own little data collection project. We took a reputable directory online of providers, and what we did is we've excluded some of the providers, for example, those like the federally qualified health centers and the larger health systems, and we did put that in our disclaimer when we did, cite this as a source in our application. But we had some graduate students over summer look at our reputable directory. I think, I'm not sure what the website was, but it's something like a doctors.com with the zip codes of our service area. And then we pulled out the entire list, and then we started making calls. And we asked, very few but key questions. First of all, do you offer language access? And yes or no. And second of all, do you offer? Do you have any open? For new patients? Are you open for new patients? And then, the third thing is we ask in terms of, are you accepting uninsured or underinsured people? So that information we were able to pull together and do our own data collection and use it as a reputable source. As long as the process for data collection is, something that's acceptable, a standard in terms of data collection practices, and use sound methodology, you can certainly use that to augment your needs statement and support your needs statement.
So can you hear me?
Yes.
Oh, good. I'd like to echo a couple of things that Michael said. It's really, really important that the provider survey is done appropriately so that you really get that true reflection of access that he's talking about. Having people, if you have populations that are really limited in English proficiency, having people call up and just randomly try to make appointments in that language to see if anyone can even answer the phone. Even getting into, like, do you accept new Medicaid patients? Well, actually, how many hours of the provider's primary care time is spent treating new Medicaid patients? Questions like that that really allow you to quantify it, and using graduate students or students who can do it, using a community-based organization that is not the health center or the applicant is helpful in showing that objective separation that HRSA and the Bureau will be looking for. Also echoing his comments on using resources to have an outside person help with the data collection, also having them help with reading it through to see if it makes sense. That if they can come away from it feeling like, oh yeah, I get this, then it increases the likelihood that the reviewers will come away with, yeah, this makes sense as well.
Thank you, Pamela. Pamela, I also wanted to prompt you. I know at the beginning we had the poll just kind of indicating the spread of folks' readiness and what they were considering in applying for the new access point, either over the next 3 years or this current application cycle or next year.
Yeah, so yeah, sure. It's off the topic of this webinar, but I've had a couple conversations with a couple people at the Bureau of Primary Health Care, and over people's strategic thinking around whether to apply for this round. And the comment was made to me by someone rather high up over there. People should not think of this funding opportunity as being $100 million on the table. They should think of it as being $1.4 billion on the table. So that's the amount of money that's left in the Health Center Trust Fund. What I took from the conversations I had was that, there's been a lot of new access point funding opportunity over the last 5 years, and this year there's $1.4 billion in expansion funding on the table, not all of which will, of course, go to expansion funding, but what they did last time there was a big pile of money was they funded one round from the applicants that had put in, and then a year later went back to the pile of already submitted applications and funded a whole lot more out of the people who had applied at that original time and did not put out a new funding opportunity. I have a very strong feeling that that was the message that was being given, was that if you don't apply now, you might be missing out for a very long time. I don't think any of us, yeah? Let me just finish, Michael. I don't think any of us, have that crystal ball to know what Congress is going to decide to do, who's going to get elected, how are their feelings about health centers. But there's no doubt that everyone is saying there has been $11 billion handed to health centers over the last 5 years. I'm not sure what the future holds. So I'm just saying that.
I'd like to just echo that sentiment from Pam, and I'll share with you with full disclosure that Asia was one of those that were funded in the second round. That is that initially when we applied, we weren't funded, and that's the initial award amount. I mean, the funds available for FQHCs, it was a pretty small amount that only a small, what was it, Pam, like 25 or 50 across the country?
Very, I think it was like maybe 37, maybe even less than that.
Yeah, and then the second round of monies that were made available, there were what, 300?
Yeah, there was over 260 that were funded.
Yeah, and we were one of them, and I believe, I think this is public information, but I think nearly 10 different AA&NHOPI-serving organizations received health center FQHC funding. So, folks, the thing with this is as daunting as the application is, I would encourage you to be very persistent and aggressive about moving forward, because a lot of it is also timing. That's important in kind of determining whether you move forward or not. And understandably, you folks might be in a situation where you don't have the you don't think you're ready. And certainly, I think those are conversations you might want to have one-on-one with AAPCHO, who could provide you some guidance and thoughts on that, and then determine from there.
Yeah, it's the applications are considered live for a year from the day you get the letter saying you were not funded this time. And the statutorily defined special populations have an edge in the competition because of the requirement of how the funding is distributed. So we were all thrilled when the 280 or whatever additional ones got funded. But anyway, just something, putting it out there that you don't even have to take the money if you're not ready if you get it. But if you don't play, you definitely can't win.
Now's the time.
Now's the time. I've got to tell you, now's the time. Although if you're not registered with SAM and all that other stuff, the deadline is Wednesday for your grants.gov submissions. So
Good.
It's a little late.
Too. So yeah, I just had one question from Beverly Harbin for you, Pamela. In our service area, we have a large population of Pacific Islanders, Native Hawaiians, and Filipino population. We also have a loss of providers. These populations have common health issues such as chronic disease, heart disease, particularly diabetes. These populations all have specific cultural needs and, in many cases, language needs. Can all three be one of the same population, target population, given the common diseases? So can a target population be determined by health disparity?
Okay. Hi, Bev. How you doing?
Beverly, we'll go ahead and unmute you as well. Sorry.
Hi, Bev. Anyway, doesn't matter. You can't define a target population by a disease status or a disease category. What you would be doing is you would have one target population, and when you're describing that target population, you would say, well, a third of it is Filipino, a third of it is Pacific Islander, whatever it is, the way it breaks down. But when you get to reporting your data, then you only have one data point for access to prenatal care. You have one data point for infant mortality rate, et cetera, et cetera, et cetera. So you would have to be able to make some kind of weighted data that would show, although I think in a lot of the way that data is collected, although maybe not where you are because folks are much more sensitive to the different ethnicities that would be defined under, you know, AA populations, which other states on the mainland may not. Sometimes the data just comes that way, that, you know, you already get it aggregated, but if not, you're going to have to put it together. But you can't come in and say, you know, well, our target population are people with chronic, you know, obstructive lung disease or something like that, if that's what the question is. Did I answer it?
I believe so, yeah.
Okay.
So one last question. Is there such a thing, I mean, Pam, I'm wondering if there is an ideal sort of average size of a target population for a new access point that they should be considering. I mean, you talked a lot about just the difficulties in going too large and how that can kind of dilute your target numbers. But is there an average recommended size that's
no, absolutely not. It's averages, first of all, don't mean anything. The average of 1 in 10 is 5, and the average of 4 and 6 is 5. So telling me an average of 5 doesn't give me any information. That's the statistician in me. No, it's so there's two different ways of looking at it, and if you, what Michael said was they took a look at what they thought their ultimate capacity was. You know, what could they realistically, how big of a space do you have? How many exam rooms? How many providers? What is the productivity rate? That all feeds into how many people can I realistically project that I'll serve. But what I will say is that there's kind of a sort of, nobody will admit it, but it's sort of kind of out there, look at about $200 a federal grant head, and you do the math on that, and if you want to ask for $650,000 under normal, regular circumstances, even though the Bureau will tell you they don't do this, you're looking at about 4,000 people that you want to end up adding or serving in the end, depending on whether or not you're already an existing provider. And backing off from there, if you have some unusual expenses, such as the location you're in, if you're on one of the South Pacific Islands or in Hawaii, you know, or Alaska, it costs a lot more to get supplies. If you have to fly in specialists, you know, like I know Diana out in Lanai and the Hawaiian Islands has to fly in her nurse practitioners from Oahu, and that's an expense that other health centers wouldn't have, and that factors into her being able to request more funds to support a project of a lower number of people. So it's kind of those two things put together, or those three things.
Thanks so much.
No problem.
So right now, I just said thank you. And it looks like at this time we don't have any other questions coming in from the group. So with that, I also just wanted to first thank you so much, Pamela and Michael, for your time and actually in being able to assemble and work with us to provide this webinar in just a matter of weeks. So thank you both for the opportunity to talk to folks. And also just for anybody on the call who would like any additional information or has questions or concerns, they can go ahead and contact me. My contact information is here, or visit our website for more information. Oh, sorry, Marianne. Okay, we see your question.
Oh, okay.
Is there one more?
Yeah, can you hear me? Can you hear me okay?
Go ahead.
Okay, so my question is, hi, I'm Mary Ann Fu. I'm with AAPCHO in Orange County, California. So we serve quite a bit of the population, 33,000, but we've provided mainly mental health clinical services, case management, patient navigation, and working with a lot of the hospitals in navigating them through the hospitals through managed care. And then we work a lot with the uninsured in helping them access health care and health insurance. So we haven't provided direct primary care. And I know Michael had talked to me a little bit about what Asia did and doing a lot of community health outreach. Does this hurt our opportunities or chances, because we haven't actually done direct primary care, but we do we do everything else. And we do patient navigation, we work with all the healthcare providers, we've helped with screenings, and we do health fairs. So I don't know if there's been other situations. I know Michael's talked to me about his, but for Pam, if you've heard of any other places that have applied that did get FQHC status when they didn't actually have a clinic up and running.
So yes, in the world of 1,200 grantees, there have most certainly been organizations that started out providing other kinds of services. The keys to this are two things. One is that you can demonstrate in your implementation plan that within 120 days of receiving your notice of grant award, you will in fact be fully compliant and you'll be providing the complete complement of required services. The closer you are to that bar at the time that you apply, the better positioned you are in the competition.
Okay.
And even though I said, there's going to be all this money potentially, there's, I think, also going to be bazillion applications.
Mm-hmm.
The other thing I would say is that it's very important, and particularly there's this very sensitive spot about organizations that were primarily mental health providers that are now adding primary care and applying for FQHC funding.
Mm-hmm.
The FQHC funding its purpose is to provide access to primary care services for underserved populations and also primary level behavioral and oral health care services.
Okay.
So one of the things that the folks do is they look at the budgets of the applicant, and if, let's just say offhand, you have a $10 million organization and $8 million goes to behavioral and mental health services and $2 million goes to primary health care, you're not a primary health care provider
Mm-hmm.
in their minds. So you have kind of those two issues going on just from what you said, Miriam.
Uh-huh.
So you want to make sure that you are designing a primary health care program
Uh-huh.
that also provides those other great services, particularly if they're on-site and integrated.
Yeah.
And co-located. And the second thing is that you are able to move as close as possible to being a primary care provider as fast as possible.
Okay, got it. Thank you so much.
You're most welcome.
Great. I'm glad we got that question in. So we're going to have to end on that note, but also just wanted to encourage if folks still have further questions, please email me and I will connect or try to get answers with Michael and Pam.
Absolutely. Feel free to call at any time or email me directly too.
Very excellent. Thanks so much, Pam. So yeah, after the webinar closes, you all will receive a brief email from AAPCHO that will include the materials from the webinar today and then just a link to a short survey, which we would strongly appreciate if you could fill that out and help us just identify future topics as well that'll be helpful for you all in considering your application. So thank you all so much again, and we hope you have a great rest of your day.
Thank you so much for having us.
Thank you, Pam.
Bye.